Our keynote speaker for this event is Amy Elliott, who is in a much colder place than we are. She showed me the snow last time we spoke. Amy is the Chief Clinical Research Officer at the Avera Research Institute Center for Pediatric and Community Research, and leads a research team with offices in Sioux Falls, in Pine Ridge, and Rapid City, South Dakota. She is also a professor of pediatrics at the University of South Dakota School of Medicine. So her center is really focused on improving child health and development through community-based research, and I think is even recently involved in a lot of the COVID clinical trials. So she's had, much like us, she's had to pivot in various ways to accommodate the growing public health issues due to COVID-19. Amy is the principal investigator on several National Institutes of Health research efforts, including and quite notably the environmental influences on child health outcomes, or ECHO study. Amy is involved in so many of the initiatives in that ECHO project, and I think every Friday I have meetings with colleagues at Columbia and other universities, and Amy's name always comes up. So her group has been particularly involved in studies to reduce infant mortality in American Indian communities through the Safe Passage study, examining environmental influences on child health outcomes. So certainly a lot of synergy with some of the questions that we've been asking in Whole Communities, Whole Health. Amy's areas of research and scholarly interest include early child development, environmental exposures, fetal alcohol spectrum disorders, fetal and infant mortality, including sudden infant death syndrome, health disparities, maternal child health, pediatric sleep disturbances, and population health, which, you know, I think really aligns with all of the different measures that we've talked about over the last few years as being something really central to Whole Communities, Whole Health. And I think the quote included on her website, I think really finalizes that nice parallel between Amy's philosophy of science and our own. And it says, we aim to discover how we can change environment and behavior in such a way that optimizes child health and development, positively changing the trajectory of their lives. And certainly this is an aspiration we have, and we'll love to hear about Amy's work and certainly how the overlap between her research program and our interests in Whole Communities, Whole Health. So Amy, you can take it away.
Thank you so much for that very kind introduction. And I kind of feel like I'm part of your group a little bit. I got invited early on to come and help talk with a bunch of people. And we also hosted a group up here to show what we've done. And so just really resonate, and I'm very in awe of all of the things you've been able to develop to get this work done. So I'm going to share my screen here. Hopefully that works okay.
And Amy, so if anyone has questions, they can put them in the Q&A, and then we'll take them at the end of and I'll keep an eye on that for you.
That would be great. With how I have my screen set up, I don't have ready access, but just fire away when you've got some questions. So what I'm going to talk to you a little bit about is to tell you a bit about our story as we have worked on developing research in our area. South Dakota isn't necessarily known for high power research. And so what we've been really striving to do is, how do we bring cutting edge research to this area? And even expanding about that now, how do we generate our own cutting edge research that others would want to do? And this story kind of started about 20 years ago. I'm from South Dakota. I turned down a job at Hopkins as a faculty member to come back home. I was told I was ruining my career, life, and other sorts of things, but thought I was making a sacrifice at that point in time, choosing more family issues over career. And what we've been able to do over these past 20 years is really work on creating, I think, something kind of special here in South Dakota, to bring cutting edge research to our area, but research that really matters to our communities, not just to fill a gap in the literature or help get someone publications or promotions, but really to help provide an infrastructure that research that matters, can at multiple levels and can improve health, can happen. And so this is a little bit about our story. First of all, what Avera Health is. In our region, most of the major healthcare research and health research happens within the healthcare systems. We all have faculty appointments at the School of Medicine and within the universities, but they don't pay any of my salary. None of my grants go through the university. They all go through the local health systems. And that's actually true for all of the health systems in South Dakota anyway. There is health research happening within the universities, but not at the same scale as what we see in the health systems. So the health system I'm part of is called Avera Health. It covers about 72,000 square miles. I'm talking to Texas, so I know you guys know it's better to measure distance in the amount of time it takes to get from point A to point B. People understand that a little bit more. But we cross 5 states, 86 different counties, and have a strong affiliation with the University of South Dakota School of Medicine. Teach a lot of medical students, residents, and whatnot in our area. Our footprint really, though, does expand beyond the Midwest. We have a very robust telemedicine program that is scattered throughout. I think there is now 22 different states that we're part of, with over 250 different hospitals. The mission of our eCare program is to help provide healthcare services to rural health centers. So, for example, in an emergency room in a rural area, likely does not have a physician on board 24/7, at least on site. And so if an accident victim comes in, there's that time between when the patient arrives and when a physician can arrive. And our eCare system works to cover that gap, to be able to help with orders and stabilization of the patient, and then hands over care as soon as the local attending is able to attend. This was actually a title where something in the Washington Post where South Dakota actually had a positive review. If any of you stay up on the news in this area, we have not been positively mentioned in national media lately because of our COVID response, I will say. But this was actually something I think very positive, and it's really served as a benefit for us in being able to serve our region in this time of COVID. We currently have over 1,200 individuals who are a part of our home health telemedicine program, and about 500 of them are on oxygen at home and probably should be in the hospital. So this has actually been a saving grace for us as we've moved forward. In the Research Institute, we have 3 research offices, one in Sioux Falls, way on the eastern side of the state, so Minnesota's right here, Wyoming, and Montana are over on this side. In Sioux Falls, that's where I'm located. We also have an office in Rapid City and in Ogallala, Lakota, in the city of Pine Ridge, which is our largest American Indian reservation, home to about 45,000 tribal members. And just for reference, this is about a 6-hour drive going there. I have gotten asked when I've presented in DC if I get to Pine Ridge every day. No, I do not. And I should have this superimposed, but these 2 counties, Ogallala, Lakota, and Jackson, that make up the Pine Ridge Reservation, are about the same size as Connecticut. So that tends to give people a little bit of a understanding of distance. But who am I talking to? You guys have that problem in spades. So again, how we approach our studies, and I've heard so much when I'm talking to Francis and others that you guys take a similar approach, is how is it that we can design studies that take into account this regional need and what's needed in our area is going to be important to our participants, and then put the tools of the best science we can. And a lot of times we're collaborating externally and bringing people in. I've worked with colleagues from Columbia for over 20 years, and also, if we can bring these 2 things together, that's when we're going to have the most positive impact, both on science, but even more importantly on our region. And so, trying to get us no longer as that flyover state when people think of science and cutting edge research. And so, in the Northern Plains, just to provide some context, it's a state of great contrasts, and nothing spells that contrast out more than things with American Indian health. So we have this beautiful, robust, vibrant culture that exists in some very beautiful areas of our state. However, that's also home to some of the worst poverty conditions that we see in the country. And so we see this opposite this contradictory evidence of beautiful area, beautiful people in these just stark circumstances that just breed health disparities and all kinds of economic struggles and things. For example, the unemployment rate in Pine Ridge is about 85%, and it's been that way. Actually, COVID did not have much effect on the employment rate in Pine Ridge because it's so bad to begin with. So just to present a little data just on Indian health, these are just, Indian health is broken down by different service areas. There is a treaty that was signed in the 1900s that obligated the federal government to providing health care for American Indians. And so how that is done is it's divided up by these different quadrants and these different service areas. What's confusing is the name of them is the town in which the headquarters is located. And so it can be very confusing when you hear Bemidji Health Service and realize that that actually serves that whole region. And so here's just some data looking at just some basic health indicators to give you an idea of when we talk about regional need and how we've worked on trying to develop a program to help around these areas. The Aberdeen area, which is where we're in, even amongst all American Indians in the state or in the country, has the lowest life expectancy. So for United States all races, and this is a while ago, but is roughly unchanged, roughly 77 years. For the Aberdeen area, and this is both genders, it's 65 years or 66.8 years. If you would divide it between men and women, men has been as low as 57 years. And so, and again, that's even comparing to other American Indian populations across our country. And so also when we look at poverty rate, two of the most impoverished cities that have highest rates of American Indians are right in our backyard. Rapid City, where we have our office, has about 51% that are fall under the poverty line, as well as in Minneapolis, which is about 3.5 hours east of where I'm located, is about 48%. And 6 of the top 10 counties for poverty are located actually in South Dakota, with 1 in North Dakota. And so just to give you an idea of some of, we talk about social determinants of health, socioeconomic status always comes up as one of the top. That's a huge struggle in this area that infects everything that health related as well as other things. So looking at a translational research context, you know, and I know many of you are very familiar with this type of model that goes from defining the problem, identifying cause, developing interventions, and then testing those interventions for efficacy. You know, I've always attributed this model to a public health model. Scientific approach is where I first saw the citation for it. I just heard it earlier today used in talking about moving medication through pharma from inception all the way to getting it put into the field as the same amount of time, which is 17 years. Now, when you're working with communities and trying to also put some import behind it and make it meaningful to them, you can't wait 17 years before being able to produce something that is seen as valuable to your partner and to your participants. You've got to come up with ways that on each step along this way, you're giving back information that is valuable. And this is particularly important when you're working with a community in crisis, such as our tribal communities that are just having these horrific health issues and needs. And so that's just, I think, always something to be very mindful of. Sometimes we're also very content with sitting on one step for a long period of time and just continuing to identify those risk factors, for example. And we need to really challenge ourselves on continuing to go up those stairs, and that may mean bringing others in. How do we help share platforms we've developed with people who can help us move from one step to the other as we develop these things? And those are things I think we need to keep challenging ourselves to make sure that we're not being stagnant and helping thwart progress on that. So this is, sorry, there we go. This little tough to read graph, but I'll just give you the main point. This is infant mortality data in South Dakota and the United States. So on the y-axis here is the rate per 1,000, rate of deaths per 1,000. So what we see here in this light orange line is the United States as a whole. rate, which, has been actually showed a nice decline. This starts 1990, goes through 2018. We see a nice decline throughout the 1990s, largely a reflection of the Back to Sleep program. And since about the year, around 2007, 2008, right in this year, it starts to really level off, but still somewhat of a downward trajectory, okay? This dark red line is South Dakota as a whole, everyone included. And so as you can see, we kind of bebop around the US rate. More typically, we're slightly above, but there's been a couple of years where we've been a little bit below, obviously more variability because we have a lot fewer births than obviously the country. And so where we see the health disparities, when you divide out American Indians in our state from this data, and so this purple line here represents American Indians. Now, there is a very positive story here to tell, is when you look at from 1990 to 2018, actually 2019 data on this one, you can see it's a very descending line. There has been a tremendous amount of work that has been happening in this area from a variety of different entities at the tribal level, state level, federal level, private groups. I like to think research, we had a role in this as well, but this has been a tremendous effort and focus, especially amongst many of our tribal communities. And so, actually, if this trend continues, it's actually, we'll see what happens. They're just releasing the 2019 data. They've gotten behind because of COVID. Go figure, it's got our epidemiologist busy. So we'll see what ends up happening with this last one. Knowing what I've seen so far, we're right in this ballpark, so we might be stalling out a little bit at this point. But man, big improvement over where we were in the early 90s. It is actually this time period right here in the early 90s, kind of where some of the roots of what we've been able to develop in collaboration across the region, how we've been able to do that. And it was that area and time when the tribes approached the NIH and the CDC and said, why are our babies dying at almost threefold the rate as compared to other babies in the same area? And NIH pulled together a group of researchers, as they do, and 9 tribes participated as well as 1 urban area. And what they did was a retrospective study to just look at what comes up as those risk factors, what could possibly be related to contributing to these high infant mortality rates. There were 72 deaths during this time period, and again, retrospective, so outcome happens, go back and collect and see what might have led to that outcome. About half of them were confirmed as sudden infant death syndrome, and the things that they found that were surprising to them that they hadn't been looking for was that if a mom had 1 drink or more, okay, but even 1 drink qualified her for this, if she drank it all during the periconception period, and it was defined as the 3 months before to the 3 months after the point of conception, the risk of her baby dying from SIDS was 6 times higher. If she reported binge drinking, which at this point in time was defined as 5 drinks on any one occasion, it increased the risk of her baby dying from SIDS 8-fold. And that binge drinking, by the way, was in the first trimester, often before a woman even knew she was pregnant. And so those things were at the same risk level or higher than what was already a known cause of risk, which is overbundling at the time of death. So what NIH did is thought that prenatal alcohol in particular may be able to open a window to help understand some of the mechanistic issues with sudden infant death syndrome and infant mortality, especially things that might be preventable, to understand why this might be happening, and being able to identify babies before they've passed away for intervention efforts. And so they developed, put out an RFA for the Safe Passage study. It started with phase 1 pilot for 3 years, where we developed the hypotheses and the protocols and pilot and feasibility studies. I do like to mention that I have been the PI for the Northern Plains Safe Passage study since its inception. I was not 10 years old when this started, but I was about 6 months out of fellowship. And my colleagues from Columbia, Bill Pfeiffer and Michael Myers, I know Francis knows real well, who had been working in this area for years, decided it was time for South Dakota to start growing its own. I had just moved back to the state, and again, was kind of trying to figure out how to get a high-powered academic research career going in South Dakota. And they put me in the front seat, saying it was time for South Dakota to grow its own and that they would help mentor and support me in doing this. I was the only dissenting vote to have me in that role because I thought it would hurt the grant. And that's kind of how all of this started, with some very generous work by a couple of individuals that are two of the dearest people to me still today, and we still work together, talk to them almost every day on a variety of different things. And so I just always want to make sure and give credit where credit is due, because I'm not sure if an opportunity like this would have readily come up again, especially being in a small, non-academic oriented in place. And so we worked together, and the first 3 years was developing that protocol together, as well as then developing the full-scale hypothesis-driven studies. Throughout PASS, we enrolled over 12,000 mom-baby pairs. Now, the reason that the phase 2 took so long is NIH decided, rather than having multiple sites, they really wanted to focus on 2 areas to help provide answers for the 2 regions that really helped inspire some of this work and needed some of the answers. And that was South Africa and the Northern Plains. And so we were the 2 clinical sites for that. The Physiology Assessment Center out of Columbia, I mentioned Bill Pfeiffer and Michael Myers. Developmental Biology and Pathology Center that was run by Hannah Kinney at Harvard, and then Data Coordinating Center out of Boston. We ended up having 3 institutes within NIH contribute dollars to this because it started out as a relatively curtailed effort. And what ended up happening is there was such engagement from the communities that were involved and so much input and excitement around what this study could answer that institutes kept adding dollars into it, administrative supplements, increased funding to, can you do hearing tests? Can you add EEG? Can you do Doppler ultrasounds during pregnancy? Can you collect this sample? Can you do, and those things kept weaving in and really increasing what was built out into the research study. And so what ended up emerging with this was this incredibly robust study protocol that, and again, we had over 12,000 mom-baby pairs that had been enrolled in this. We'd enroll women very early in pregnancy, follow them 3 or 4 times, see them at the point of delivery for sample collection, placenta, cord blood, some survey type things, see them at 1 month and then at 12 months of age. The definition of SIDS is death of an infant without any other explanation before 12 months of age. So that was our last outcome point in this study in particular. And again, what ended up resulting was just this incredibly robust study. If a baby died during pregnancy or during that first year of life, there was an additional studies that families could participate in and could donate tissue from autopsy for additional analyses. And so it really led to this infrastructure within our hospitals, within our clinic partners. So we'd be notified of births, we'd be notified of deaths. And it really created this very integrated environment. We had 86% compliance for all study visits. Considering where this study is happening, how many visits we had, this is something that I just have been incredibly proud of. And the reason it happened is because of the people who work on the front lines and the relationships they get with women, and also really getting communities involved. It was seen as something very special to be involved in this study. And by the way, there was no inclusion criteria related to exposure. It was all comers. Which is also something I would really recommend, is making sure that when you're looking at a specific exposure, that you are opening it up to others. We found a tremendous amount of exposure that was going on. And if we had limited it to only that time it was in the medical record, we would have missed 90% of the exposures we see, maybe even 98%. And so incredible study compliance, again, which helped increase interest from all being able to participate in this study. We did have some regulatory hurdles that we had to go through. One of them is drinking during pregnancy is actually under the child abuse statute in South Dakota, which makes it then part of mandatory reporting. And so, again, drinking alcohol during pregnancy, obviously something none of us would condone, but illegal behavior in any other place when women are over the age of 21, considered a form of child abuse and people do get prosecuted on a regular basis on this. In fact, I believe there's 42 women currently, just because I talked to someone earlier this week on this, that are currently incarcerated in South Dakota for drinking alcohol during pregnancy. That's not even including other substances as well. And so that makes it very difficult to recruit women in pregnancy and ask them about alcohol use or other drug use. So we worked closely with our state Department of Social Services, and they were actually very supportive of us doing this study and realized that we would be in a position to ask questions and to offer intervention services and try to help refer women who are looking for treatment in a way that may not be able to help happen through regular channels. So we came up with a memorandum of agreement that essentially exempted us from this requirement, and it said that the state would honor our certificate of confidentiality in holding our participant information confidential and their identities confidential. And so then we were able to ask about this under an umbrella, the certificate of confidentiality protecting them. We did have sheriff's office show up at the research office in Rapid City on one time, demanding information on a participant, and this held. Again, they didn't push it a whole lot because they saw they were running against a brick wall, but we were able to really offer this to our participants, and it made really all the difference in the world. Trying to do. Also then, how do you provide intervention services and support while also protecting confidentiality? It gets to be a tough area that we actually still talk about a lot today. How we collected alcohol information, because this is always a question people ask, is we used a modified 30-day timeline follow-back procedure where you put your time period that you're interested in and have the woman mark key days down that were important during that area. We have found in particular paydays were especially critical, as well as holidays, birthdays, celebrations, those types of things. I just was thinking this may be harder to do in the area of COVID, where every day just feels like Groundhog's Day. So then we'll see what that does to alcohol assessments now. But then it could ask very detailed information once you get people kind of grounded back in that time period. We did the same thing with smoking. What it allowed us to do is we could look at the timing of exposure, you know, what trimester things happened in. We could look at the quantity on a given day or a quantity over time. And then we also could look at multiple exposure types. For example, was there alcohol use and smoking, or smoking alone, or alcohol alone? And what we were able to do then with this is create trajectories, because as you know, prenatal exposures, there's the trifecta of things you want to include: quantity, frequency, and timing. And it's very difficult to get information on every day during pregnancy on really virtually any exposure. And so what we were able to do, though, because we collected these things at multiple time periods and we had such complete data sets, we were able to form trajectories and groupings for this. So we had a high quit later group that about 10% of the population fell into, high, but still relatively continuous throughout the pregnancy, moderate, and then quit early. These, by the way, tended to be our women that quit as soon as they found out they were pregnant. That was about 25% of our total cohort. And then low continuous was about 11%. They had this weird blip in the second trimester, this group. I need to dive into this a little bit more. And then a none. Something I do want to mention is we were blind to all of the primary exposures and outcomes for PASS until the data set was complete, which was in 2017. Little difficult for someone starting out in their career to get publications. Felt like I spent just a decade studying up a study and running a study rather than analyzing data and doing that. But it's now well worth all of the effort and sweat and tears we put in. But we did just recently get this data. So some of the things I'm going to show you were just published relatively recently. And so one is related to our primary outcome, SIDS. So this is just a table right from the paper, one of the Lancet journals. We published this in just earlier this year. And what we found, and so these are different exposure levels, okay? And I showed you how we quantified some of these. These are collapsing a few. These are also after the first trimester. So these are women no drinking or they quit early, drinking only past the first trimester, smoking only past the first trimester, or both smoking and drinking past the first trimester. My OB colleagues love, by the way, that this is past the first trimester because they said it helps decrease all the nervous Nellies they get who drank before they found out they were pregnant. And obviously we want to decrease that as much as possible, but where our significant findings were is in that exposure beyond the first trimester. What we found is if a woman smoked only during that time, and this is comparing SIDS cases with those alive at 1 year, it increased risk of baby dying from SIDS almost fourfold. Smoked only increased the risk almost fivefold. However, if the woman smoked and drank beyond the first trimester, the risk of her baby dying from SIDS was 11.79, which is greater than either of these even added together. And so we really conceptualize this as a synergistic effect of these exposures on sudden infant death syndrome. Now, we also compared it with known causes of death, between known causes of death and then alive at 1 year as well. And none of these were significant, although smoking only, but 0.1, given all the corrections and things like that, they weren't considered significant at all, even though it would be interesting with a larger sample size what you would see there. But we didn't see any significance there where we did with a sudden infant death syndrome. And so then also things that we've looked at in this data set recently, this is just published this last summer, is looking at prenatal exposure. Again, trying to help bring things again to our region to see how can we help things in our area. We had 2,124 American Indian women that were included in this analysis, a little over 2,700 Caucasian women. And the question we were literally looking at is how do American Indian and Caucasian women differ in their prenatal drinking pattern, or do they? Because it is a bias, prejudice, that many people believe that American Indian women drink much more than Caucasian women drink. I've been told by clinics that primarily serve Caucasians, oh, we will be your control group. And so, but that's not what we see in our fetal alcohol syndrome clinic all the time. And so there's a disconnect between some of these different things. So we wanted to help use our data to see if we could help answer this question. And I love what we found too, because I love that this is the take-home message. So the dotted line here is drinking. The lighter line is Caucasian drinking. The black line here is American Indian drinking. And as you can see, at all time points, there was more American Indian or more Caucasian women that drank during pregnancy than American Indian. However, there's a flip side to that coin. Here, the solid lines are binge drinking. And what this is showing is that there are more American Indian women who binge drink. Of those who drank, more women, American Indian women binge drink compared to Caucasian women. And so these two main findings, that more Caucasian women drink during pregnancy. By the way, when I presented this information back to the tribes, one of the tribal chairmen said, I knew it. It was a great moment of community-based research. But those American Indian women that do drink are more likely to binge drink. And so you can see both flip sides of those coins and how they may relate to health. And by the way, a lot of animal models, and I know some of you are very familiar with this literature, binge drinking really seems to convey a higher level of later health issues, neurodevelopmental issues in the pups, and we also see this as well in the human literature. So other things we've been able to do is put out a publication looking at normative values in unexposed infants. So this is looking at how does the autonomic nervous system mature during the course of pregnancy. We had 12,000 studies from 8,000 fetuses that we were able to include in this and really be able to just look at unexposed infants. So now that we've got normative data, it will be easier to be able to know what does abnormal look like, and especially along that trajectory of time. And so we've also included EEGs were added onto the study protocol. And so what I'm trying to show here is just the whole variety of, by creating this cohort and this platform of research, we've been able to add all of these different elements so similar to what some of your vision is as well. And it really has it makes things fun. We're learning something new all the time. And there's so many questions that I may have this thread to this question as an investigator, but someone else has this one, and we can help combine them and really get that transdisciplinary science rolling. And so here's things that we've done with both prenatal exposure and infant EEG. This is a 64 lead EEG that we put on. And again, we had enough data that we could put smoking clusters by groups, alcohol by groups, and then look at, so for example, what if they had low continuous alcohol and no smoking? Quit early alcohol and moderate smoking. In some of these, categories get a little bit low, but I'm guessing for most of this research, 48 would be seen as quite a bit. And so in total, 1,739 ended up being able to be included in this analysis. Some of you I know this very well. Here's putting on the EEG cap. This is a couple of my star individuals working on this, and just to show that the baby didn't even wake up. Now, if I show this in front of my clinical coordinators, they're all rolling their eyes going, yeah, you picked the best example on these things. But, here's just how this goes. This is happening right in the newborn nursery that we're doing this particular one. Sometimes we do them in our research office as well. Just some data from this published earlier in JAMA Network Open. And what's real interesting about this is we saw different main effects across with alcohol on different areas of the brain that seem to be affected by this. Now, again, these are in newborns. And now we're following these kids for a longer time period. The youngest is 4, the oldest is 12. And we're following a good portion of these kids and having them come back in and do repeat EEGs, looking at attention, executive function tasks, things like that. But we also have all this wealth of data from when they were infants. So it really capitalizing on that longitudinal aspect of things. The other thing in doing community-based research is having a sense of urgency when there is a crisis and an issue. Obviously, infant death has been huge in this area to look at. One of the things that we noticed, and we did not need to wait for the end of PASS to find this out, is that so many of our babies were dying sleep-related deaths, usually related to something in the environment, co-sleeping in particular, especially if a parent was compromised in any way. So what we were able to do, and this was in combination with our community advisory board, because we would talk about co-sleeping and I would get the explanation back, it's cultural. And we really started discussing what does that mean? And because it didn't make it less of a risk factor to have co-sleeping happening, especially with multiple people in a bed or on a couch, recliners, those sorts of things. And so we decided to challenge ourselves as a group and see if we could combine somehow this Western view of thought and traditional view of thought. Could we combine these things to make a more powerful message that would help reduce risk and protect babies? And so we came up with this study. I have actually been, my Lakota is so incredibly poor that someone said, we appreciate you trying, but yes, it's a beautiful language and my tongue just doesn't quite get it. But anyway, so we got an R01 to be able to really look at, could we accomplish this goal of creating this joint curriculum and combining these things? It took us 2 years to come up with a curriculum. And at first, I didn't think we were going to be able to accomplish this. But actually, we have now finished recruitment. We have 118 women. By the way, this is a completely randomized clinical trial format with an intervention and an attention control group. Recruitment's done, and we are actually, the final analyses are in place right now. And so it's been really kind of one of those fun projects. The community stayed very involved in it, and we're excited to see how this turns out. The other chapter to our story, and Frances mentioned, we're part of the ECHO National Network. This has allowed us to follow up our kids. And so the mission of ECHO fits very well with us to enhance the health of children for generations to come. We're part of a national study with 50,000. We represent almost 5,000 of this 50,000, which means 10% of this national cohort could be coming right from our area, which we're very proud of that. There's major outcomes associated with ECHO actually that resonate really well with our community. We're focusing a lot on asthma, autism, as well as in childhood obesity are some of the areas, but we're contributing to all of these outcomes with about 1,200 scientists from across the country. And so being able to, again, bring that cutting edge research here and having our data used along with everyone else's to help answer really some fun questions. So we currently have, this data's a little bit old, my team would be smacking me upside the head on that. But we've had about 2165 of the original cohort that have consented to sharing their data with ECHO, and then we're slowly enrolling them in a much larger study, and we currently have about 1,100 enrolled in that. We are starting a new pregnancy cohort as well, so that we keep, I think one of the things also keeping in mind in doing child development is your kids are going to get older, right? And so how do you keep kind of populating it maybe with a new prenatal cohort so that you can take some things you've learned and apply there and kind of have things at multiple different developmental levels, which I'm really glad we're doing. We currently have, actually it's over 600 enrolled right now that we're doing. We've had to transition to completely remote consenting as well as data collection. So that's been a challenge that I know you guys are facing too. But as of just a couple months ago, we had completed over 6,100 study visits. A whole host of things, just like with PASS, we're collecting as part of ECHO. Some of this is part of the ECHO-wide common protocol, which is actually mammoth. And some of this are site-specific things that we're particularly looking at. So these are just kind of the general categories. This was pre-COVID. You know, we'd see them multiple times during pregnancy, delivery, 1 month, 6 months, we go to their home and vacuum for different environmental samples, a couple times then during early childhood, and then up through age 13. So we've had to transition a lot of this to figure out how to do things remotely, how to do specimen collections, and we're even piloting a single lead EEG. Now, I'm not sure how comparable this is going to actually be to our 64 lead EEG, but it's something. So we're going to have kids wear this overnight because you can actually then, with the single lead EEG, we can get sleep state. And so we're going to have an EEG and an EKG. So then we can also look at coupling and relate those two things to each other. So we're piloting this right now to see how we can get them out there and how we can get them back. And we're doing it with our most impoverished group in Rapid City, because we know if we can get it to work well with that group, then we can do it anywhere. And so that is currently, well, stay tuned. Hopefully that will go well. So basic lessons, and I know many of you guys, I'm preaching to the choir on these things, but you cannot underemphasize the importance of these community partnerships, and not just looking at them as your external partner, but as truly part of your team that helps identify important questions, helps you get supports that you need, that informs design, and then also is part of that analytic process and things like that. Now, you don't want to waste people's time on things that they're not interested in, such as data quality discussions, for example. We just had one recently. And our partner was like, I don't think I need to be part of this. But you want to include people in as many different components as you can, and dissemination cannot be underemphasized as well. Because you've got to show that there's something in it for them to participate. And everyone who's in this field is doing it for a reason to help others. And so also having a lot of respect and support for any regulatory processes is absolutely key. And realizing when we work with tribes, we're a guest. We will always be a guest. And their regulatory processes are first and foremost the most important. And also that the timeline could be expected to be a little bit longer. We're right here in infant mortality. We're at 15 years. And if we get our analyses all done and I can get it published this fall, we're going to do it before 17 years. So that's a good goal. NIH has been very gracious in helping fund us for the last 20 years on this work, and hopefully for the next 20. If we keep being able to, I think, answer important questions and do it in a way that maybe others can't as much. This is the team that really makes everything happen. And so thank you for your time.
Terrific. Thank you so much, Amy. If anyone has any questions, you can put them in the Q&A, or if you're a panelist, I think you might be able to unmute, although Allison might be able to tell me otherwise. Just to get things started, Amy, you know, what are your thoughts on encouraging, you know, we do tend to focus on the problems and the risk factors, and finding that balance, you know, and trying to introduce a less deficits-based model and more, you know, what are the things that can promote health as opposed to those that detract from it. How has your team been approaching that?
Yeah, well, and I tell you, I think we as clinicians as well as scientists are much better at focusing at problems. That is how we've been trained. That is how we think. But yet that is not what resonates with our families, especially with our tribes. I can't tell you how many times I've been told, can you tell us some things we're doing right? All we get told are things we're doing wrong. And you think about that, as a parent, for example, if you're constantly telling your kid what's going wrong and what they should do to be better, you're going to just crush their spirits. And how is it that we can encourage things as well? And so we've really tried, no matter what question we're asking, is looking for that resiliency. Some aspect of it, even in our comparisons when we compare across race, our hypothesis was actually that more Caucasian women would drink during pregnancy because that's what we have seen as we've worked with all of these women. And just trying to also challenge some of those status quo and things that are out there. I think virtually every question you can find things related to resiliency and not just risk factors, but protective factors. But you have to incorporate them in your data collection. And a lot of times those measures are kind of wishy-washy. At least a lot of the ones that I've seen. So we've looked at different things like how do we look at physiology and matching of physiology between mom and baby as a positive marker of attachment. How do you get creative in that? So I think we just need to keep challenging ourselves in that because that is what communities want to see more of.
A question from Sarah Kate Behrman in the Q&A. So can you talk a bit about how you approach data collection, interpretation, and presentation of results of a minoritized group as a member of that group? So how do you convey that message and gain that trust?
Yeah, no, I actually have a presentation that I give to the med students on what it's like being white working in American Indian health. Research is part of what we do. Obviously, we do lots of other things too, but I give it with one of my lab manager in Pine Ridge, she's American Indian. We worked together for 12 years. And so we do this together about how she's kind of had to smack me upside the head and bring me up right in some of these things. I think the first thing is just be very humble, but also not trying to, when I first started working in this area, and Deb Tobacco is the one who called me out on this, I was being very, almost like overly cautious and protective, almost like a maternalistic type perspective where I was, just wanting to make things better and not really realizing and recognizing the strength that exists in the community. And they don't need me to make things better. They need my help as a scientist to bring the best tools possible to help answer questions they're interested in. But I also should do my job on that and not try to do other things outside of that job. And so I've just found being very straightforward on what my role is, what I can offer, and what it is that we can tell about this has been, and again, sometimes you still get criticized for all kinds of things, but at least then you're sticking with your skill set and stuff that you know. One of the things we really grapple with now is how much to use race as an actual grouping variable when it seems that socioeconomic status is much more robust than and really might be the better way to look at it. And so I think sometimes how we've done these different comparisons could contribute to health disparities rather than help. So that's an active conversation we're having right now to try to help do things better. Anyway, sorry, could talk about that forever because that has been,
actually, and some of the groups here that look at health equity have really been trying to emphasize the need to say, for example, for COVID disparities, that race is not the issue. It's the racism that people experience and the socioeconomic context that brings. It's not something inherent in race. But
we've just in this last year. And this last year, and I think with all of the increased conversations around some of these things, we now are including a discrimination measure in everything we use, and are really thinking that could be a much better variable to be able to use. So I think this is going to be an area really fun to see how this develops and improves over the upcoming couple of next few years. Well, hopefully not even doesn't take that long.
Absolutely. Okay, another question from Jennifer Gardner. You mentioned how you've been able to piggyback several studies onto the original scope of the cohort study. Did the community itself bring forward the ideas or requests for any piggyback studies? And were there times where you had to find a compromise between what the community wanted to learn about itself versus what your research team is capable of studying?
Oh, yes, yes, and yes.
Discuss all the time.
Yes, yes, and yes. Yes, we did have the community bring forward many different things that they wanted incorporated within the study. Greater emphasis on stress during pregnancy and depression, which was completely, by the way, this was in the early 2000s. If that was brought up now, you'd be really in in vogue, right? That's what's being looked at now. They were so ahead of the game and helped and incorporated some of those, even though we knew it was important. I don't think nearly to the level that we recognize now how important those things are. And so, yes, but they contributed in such a way that it would be difficult to point out this was community recommended, this was science recommended, because then it became such a discussion. We also had clinicians who would bring forward things that they were seeing in the clinic. One of the things that we do for community partners, and I think we shared this with your team when they came to visit, we give summary aggregate, de-identified, just descriptive data of things we're finding from their patients that are in the study. They have to have at least 25 individuals that have enrolled in the study for us to do this, kind of a recruitment tool as well. And then we give them this whole document. And then anytime a clinician asks a question, we'll keep adding to it. And so I think the document's like 18 pages long now of descriptive data. It will also show, as with the cohort as a whole compared to their clinic, how does that end up looking? And so clinics have contributed pieces as well, but that's almost been more of, do you have any data on this? How about this? Could you look at this for us? And some of that has then led to additional studies. We've also had both tribes and clinics use some of our data to support like service grants they were going after. So it's been great to see the data be able to use in a way that's like immediately helpful to them. And I think there was one more question in there that I'm forgetting. Or did I get them all?
Got it. No, you got it.
Okay.
So a question from Kaya, your compliance rates are very inspiring. Can you talk about what you've learned about best practices for keeping participants engaged in a research study?
Yes. Listen to your coordinators on if you're asking too much. Rule number one, because we tend to do that, and I do that all the time. I really think that relationship with the coordinators and making sure they have that time to develop that relationship with them. This has been one of our biggest pieces of conversation around COVID, is how is having to do everything remotely actually hindering developing that relationship, and what is that going to do with our compliance rates and our ability to answer questions? And it's a big concern area we have right now, but make sure your coordinators have time to develop that relationship, and then make sure there's frequent information of like, hey, look, we just found this. We do one-page layman summaries of every publication that are available to our participants. We push things out on Facebook. We could do better with social media, but that some of the things that we do, some people are interested and some people aren't as much, but we are looking more and more into return of results. I'll be interested where you guys land on that, and you might be able to, we're trying to really increase that area as well.
Yeah, I think we're really working now to think about the dashboard, the interface and exchange, and how that looks and how people can customize it to based on what they're actually interested in seeing.
Maybe we can partner on that.
A question from Melissa Miller. Yeah, that would be great. Can you talk about how you are educating the community on your research findings? You spoke a little bit to this, but are there other forums that you use?
You know, we try to put things in the paper. Yeah, We also, though, put ads in the paper, sometimes with things that we're finding. One of our better things is there's radio stations that people listen to and get a lot of information from. So we'll do like live radio shows. Something else that I've learned is try to not dumb it down too much. I mean, you've got to make sure people understand the variables, that they get the points of it. But I don't need to, if you talk about your findings like you would to, a colleague from a different discipline, but make sure that you're explaining your language and really showing the implication of it. It really makes it show the depth of some of the research. And so I've actually changed over the years how I talk in communities and make it a little bit more detailed and nuanced. And actually, I think it goes much better than it used to. I think I used to water it down too much and they felt like, this doesn't tell us anything. So that's just something I've been playing around with and trying to get better.
And can you talk about the strategies for reducing that overall timeline from study design to implementable outcomes? So is there a way to reduce that 17-year timeline? And what are your thoughts, having gone through most of the stages now?
I think this is going to be one of the benefits of COVID. Being involved on some of the COVID trials and things like that, we're learning how to do things fast. I do worry about that as well. But I do think some of the regulatory processes and things like that, it'll be really interesting to see as we move forward what may change. Also, big things like echo. We're able to put COVID surveys into the field in echo time in relatively quick fashion. How do we have a fast track to be able to get these things moved through, to be able to get interventions? So I'm hoping we'll learn from some of this. This is something, though, I struggle with, also because we don't have an army of postdocs or other. We're limited by our numbers sometimes as well. For us, the biggest way to decrease this is to make sure we're collaborating and pulling as many people we can in to work on problems and issues so that we've got more resources towards it. But that's something we struggle with too.
And maybe one final question from me. So one of the topics we discussed this morning with Bill was mobile EEG units. So we were talking, because one of the things that we've been talking about in Whole Communities Whole Health is a mobile storefront. So, basically a very nice RV, which brings the science to the participants as opposed to bringing participants to the lab. And I know this is something that you guys have been thinking about. Where are you at with that, and how you're thinking about redesigning the approach to science?
We're going to try to turn it on its head. We've been working with Sean Dione and his research team out of Brown University on a completely mobile MRI unit. It's not a 3 Tesla, but it's not bad. It does really good imaging, and we actually, if any of you know Sean, this wouldn't surprise you, but he did a live feed during a national meeting on the first administration of this in a participant's driveway. I think the child was 9 years old, and it's on YouTube as well right now. And so anyway, so we're looking at creating, and he's got a van and puts this unit in it. The total unit, everything, is about $110,000, and it runs on its own battery. You don't even have to plug it in anywhere. And so we could bring that to the most rural areas of South Dakota. We're also working with Southwest Virginia in the heart of the Appalachians on this as well, where to have somebody drive to a research center, especially any that would have a top of the line imaging facility, they'd be driving 6-7 hours. And we can bring this right to people. So this is part of the HBCD study, Healthy Brain and Cognitive Development study that we're looking at. And we're really trying to push that program. And I'll say push because we do not have uniform agreement on this across all partners, that to collect information on some of these populations that really need to be included in this type of research, we need to look at these sorts of mobile options to push them forward. So we'll see if they keep letting us play in the sandbox on that. But yeah, so we'll be looking actually with, as long as the funding keeps rolling in. We'll be getting, I'm hoping, 3 of those units that we're going to just have driving all over South Dakota here very soon.
That's great. So thank you so much, Amy. It was terrific to have your insights, and you are officially, I think, part of this initiative. So we will keep you in the loop on everything that's going on. I hope to have you at future events as well. So thank you so much.